Hello, my name is Skip Olson. I'm a physical therapist here at the Saunders Group. On behalf of Robin and Dwayne Saunders and all the employees at the Saunders Group, I'd like to welcome you to this 3D ActivTrac training. Today we're going to concentrate on advanced three-dimensional techniques. I assume that you're already familiar with the basic table functions found in the user's guide and in the traction treatment guide. Before we continue with the training, I'm going to review the content of the 8 modules that we're going to talk about today. In Module 1, we're going to discuss how to treat a laterally shifted disc patient with a flexed posture and peripheral symptoms. In Module number 2, we're going to cover how to treat restricted lumbosacral extension. In Module number 3, we're going to demonstrate how to treat a specific joint dysfunction using manually assisted techniques. In Module number 4, we're going to show you how to improve range of motion in basic movement patterns. In Module number 5, we're going to demonstrate how to treat lateral stenosis with peripheral symptoms from degenerative disc and degenerative joint disease. In Module number 6, we're going to show you how to mobilize a nerve root adhesion using nerve gliding techniques and flossing techniques. In Module number 7, we're going to show you how to treat cervical spondylosis with peripheral symptoms. And in Module number 8, we're going to show you how to treat restricted hip motion from moderate degenerative joint disease. We have a lot to cover today, so let's get started. In Module 1, we're going to discuss how to treat a laterally shifted disc patient with a flexed posture and peripheral symptoms. This is one of the most important and difficult patients to treat. It's important because if we don't get this patient better, they're likely to go on to surgery or have to live in chronic pain. And this is a difficult patient to treat because if we pull this patient in a straight line, their back symptoms and leg symptoms will likely get worse. Theoretically, we feel this is because the disc bulge is being pulled onto the nerve. Today we'll be assisted by Tim Hansen, who has agreed to be our subject for today's demonstration, and thanks, Tim. As you can see, we've asked Tim to remove his belt and to take the large objects out of his pockets. We're going to ask Tim to assume a typical antalgic posture. Tim's pain would be on the right. He's shifted off to the left. All right, well, let's get started. What I've done here is I've matched the table to Tim's lateral shift. He had a flexed lumbar posture, so I flexed the table. He was shifted off to the left, so I've moved the table to the left. Remember, we have controls on both sides of the table, so you don't have to reach over. And I made that lateral adjustment to match his lateral shift. Then I made small adjustments to improve his comfort. I've placed the belts so that the lumbar harness is about 1 inch over the top of the hips. I snugged the belts up. I placed the thoracic harness, overlapping it about 1 inch over the lumbar harness. That has been snugged up. And now this is the key to a real good traction technique. We've got to aggressively take the slack out. We start by pulling on both straps, and then we take the slack out of each individual strap so that when we're all done, the straps are nice and snug. That way the patient won't slip. The belts have slid into place. There's no slack up in the upper thoracic belt, and we're all set to go. The next thing we're going to do is to program in the protocols. We're going to choose lumbar, static. We're going to choose ramp up and ramp down times of 1 minute because this patient would be in acute pain. We can choose 2 or 3 minutes if necessary, but 1 minute for acute pain is usually enough. We're going to choose a treatment time of 10 minutes. We know that the range is usually 8 to 12 minutes. For this patient, I think 10 minutes will be just fine. We're going to choose a treatment force, a starting force of approximately 40% of Tim's body weight, which works out to be about 95 pounds. As the treatment goes on, we're going to try to increase that to about 50% of his body weight for the first treatment. We find that 50% body weight is usually therapeutic. We also want to remind people that if somebody is grossly overweight, we do not count that extra weight as part of their body weight, so maybe the term we should use is ideal body weight. The range of treatment, 40 to 60% of ideal body weight. So we'll set 95 pounds. We've got the treatment time of 10 minutes. The next thing we'll do is to unlock the table. We have two sets of controls, and so we don't have to reach over the table. Once the table is unlocked, we'll give Tim the patient control switch and instruct him that if he needs to shut the treatment off at any time, he can just push the little red button. For demonstration purposes, let's assume that 3 minutes of treatment time have elapsed. It usually takes about 3 to 5 minutes before the muscles relax and the vertebrae distract. This causes or allows the decompressive effect to centralize the disc, take pressure off the nerves, and allows us to start moving that patient back into a neutral posture. We always start by correcting the lateral component of their antalgic posture first. So just while the table is pulling during the distraction force, we'll very, very, very slowly, a degree or two at the time, correct that lateral shift. Sometimes we can correct the entire shift, the first treatment. Let's just assume that we can do so. It might take a minute, possibly 2 minutes to correct that lateral shift. Next, we're going to correct the flex component of the antalgic posture. We're going to extend the patient towards neutral 1 or 2 degrees at a time. We're going to do this as tolerated. What we're going to try to do is we're going to try to get a reduction in peripheral symptoms, less leg pain, without significantly increasing the back pain. A temporary, mild increase in discomfort during this technique is acceptable, but what we don't want to do is increase peripheral symptoms. If things are working well, we're actually going to get a reduction in leg symptoms with this technique. Once we've corrected the lateral shift and flexed posture, we'll allow the rest of the treatment to be completed. Okay, once the treatment's completed, we want to carefully help Tim off the table, and at that time we can apply a lumbosacral corset to aid in the healing and protect the spine from harmful postures such as the flexed body posture. We also can instruct Tim in extension principles, elbow props, press-ups, standing backward bends, and so on to help get that and keep that disc back in place. It's also important to instruct Tim in proper body mechanics, sitting postures, using a lumbar roll, trying to maintain that neutral posture to aid in the healing process. We also want to talk about ergonomic considerations if he's back at work. Let's review the key elements of treating an acute herniated disc with a lateral shift and a flexed lumbar posture. Number one, we have to decompress that patient in their lateral shift. Number two, after 3 to 5 minutes, we reduce or eliminate the lateral component. Number three, once the lateral component is corrected, we correct the flex component. Number four, once the treatment has been completed, we instruct the patient in how to maintain neutral postures until healing has occurred. In module number 2, we're going to show you how to treat one of the most common and difficult conditions in the lumbar spine. That is restricted lumbosacral backward bending with a hypermobility at the thoracolumbar area. Remember, 80% of the extension in the spine is at the lumbosacral area. And as this area degenerates and stiffens, it forces the motion into the thoracolumbar area, which becomes hypermobile. These patients can have pain from the stiffness in the lumbosacral area, or they can have pain from the hypermobility in the thoracolumbar area, or both. What makes this condition difficult to treat is if you just give this patient extension exercises, they'll just increase the hypermobility in the thoracolumbar area. To To start this treatment out, I have stabilized him with a slimline belt. This covers the thoracolumbar area and extends down to about L4. L5 spinous process is right here. I've used the harness across Tim's hips, and I've placed an additional slimline belt across the sacrum so that the focus of our movement will be right in the lumbosacral area. I've eliminated the slack, and now I'm ready to program the treatment. We'll choose lumbar, we'll choose static, we'll choose a ramp up and ramp down time of 30 seconds. This patient wouldn't necessarily have acute pain. We'll choose 10 minutes treatment time, and we'll again start out at about 40% of his ideal body weight, increase as he tolerates it to 50 and then to 60% of his ideal body weight. We'll provide Tim with the patient control switch, and we will start the treatment. For purposes of demonstration, let's assume that 3 to 5 minutes has gone by and that the back muscles have relaxed, some discomfort has been relieved, and now we're ready to start some very, very specific stretching right in the lumbosacral area. The way I like to explain this treatment to patients is to relate to somebody's fractured finger. If you were to fracture your finger and it was in a splint for a month or 6 weeks and it was time to start to bend your finger, if you took that finger and just bent it, it would hurt a lot after not moving for a few weeks. But if you distract the finger and then you bend it, it's much, much more comfortable. And the same thing goes with the spine, even more important. Because when we distract the spine, it takes away the pain, the muscles relax. And when we do the stretch very specifically to this area, you would be surprised how much stretching you can get with so little discomfort. It really works well. Here we go. Now, we do this with the person distracted. 50 to 60% of the ideal body weight, and this a degree or two at a time, we start bringing Tim into extension. If you want, you can add manual techniques. You can use posterior-anterior techniques. You can use thumb pressures, or you can just let the table do the work for you. And we'll keep taking him up into extension. We want at least a moderate stretch. If it's a mild stretch, we're probably wasting our time. If a person feels a very heavy stretch, that's probably too much. Remember, when people are distracted and you stretch them, that force is magnified, so you don't have to have a real heavy stretch to be very effective with this technique. Once we've taken the patient into a moderate stretch, we leave the patient in that position and allow the treatment to be completed. It's important that once the treatment is completed, that we reassess the patient. You're going to notice several things, and the patient's going to notice several things. They're going to have much more lumbosacral extension. They're going to have less pain with that motion. They're going to be able to walk a further distance without pain, and they're going to be able to stand for prolonged periods of time with less discomfort. This is an amazing treatment. This improvement is slow but sure. What I tell patients is they're going to make 3 steps up in range of motion, and by the next day they'll have taken 2 steps back. Each day 3 steps up, the next day 2 steps back, no problem, but they're slowly, slowly going to improve. This treatment is awesome, it really works, and there are so many patients that can benefit from this treatment. It's easy on the patient and it's easy on the clinician. The key points we talked about in module number 2. Number 1, it's very, very important to be very precise with your stabilization. We want to stabilize down to L4 and then stabilize over the sacrum. That focuses that backward bending right in the lumbosacral area. Key point number 2, we want to wait about 3 to 5 minutes before we start our stretch. That allows that spine to distract, muscles to relax, takes away the pain, and allows that stretching to be very effective and very comfortable. Key point number 3, you can add some mobilizations. Use a piezoform contact, use your thumbs, add some motion into that stretch, and it will be even more effective yet. And in key point number 4, we have to remember that this is a chronic condition. It took a long time for this condition to occur, and it's going to take them some time to get better. I use the analogy 3 steps up, 2 steps back. We're going to gain quite a bit of motion with each treatment, but during the night and over the next day, we're going to slip back a little bit, but each day will be a little bit better. And the patient is going to feel that. They're going to sense the ability to walk further without pain. They're going to be able to stand a longer period of time without pain. The key message here is to be patient, stick with it, and you're going to get a lot better. This is a tremendous treatment. In module number 3, we're going to demonstrate how to treat a specific joint restriction. This is definitely one of my favorite techniques. This is a technique that would be done in place of a high-velocity thrust manipulation. I know many clinicians are very good at high-velocity thrust manipulation, but in many cases, high-velocity thrust is not indicated. I'll give you a couple of examples. If you have somebody that's afraid of being manipulated, maybe they have some osteoporosis, or maybe they have an adjacent acute herniated disc and you just do not want to manipulate this patient, yet you want to correct this joint restriction, this technique will work just great. I've already examined Tim, and I've actually found a problem, a restriction, and he has discomfort in the supraspinous area. The muscles, particularly on the right side of his upper lumbar spine, are very tight, and I see a positional fault. He is actually right rotated at L2 on L3, and so we have an actual problem here, and I have drawn that problem on his back just to help me get my proper finger positions once I start the treatment. What I've done here is stabilize Tim using a slimline belt across the mid-thoracic region, and I've used the traditional harness across the hips. I've taken out the slack, I've tightened up this belt snug, and right now he is stabilized and ready for his traction treatment. We're going to set in the protocols: lumbar, static. We're going to have a short ramp-up time because this condition is not an acute condition, so we'll use 30 seconds ramp up and ramp down. We will set a treatment time of 10 minutes, and we'll use a treatment force starting at 40% of body weight, and then we'll increase that up to 50 and eventually up to approximately 60% of body weight. And again, we'll use ideal body weight if Tim was overweight, which he is not. We will give Tim the patient control switch, and we can start our treatment. Just like in the other techniques, after 3 to 5 minutes, the muscles relax, distraction occurs, decompression occurs, and we're ready to start correcting this specific joint restriction with some manually assisted techniques. Now, we have been very precise with our diagnosis, and we know that there are many different ways to diagnose these conditions, and each clinician will be a little bit different. Once we have completed our 3 to 5 minutes, there are several different ways to manually assist the correction of this problem. We can use our thumbs and go over the transverse processes, press straight down, and oscillate. I like 3 sets of 10, pressing straight down. Or we can take and use our thumbs and provide a lateral force through the spinous processes, and again, oscillate. And even a very stubborn condition, at least 90% of the time, will correct within approximately 1 minute. Usually 3 sets of 10, just 3 sets of 10 oscillations, you'll start to feel those muscles melt under your fingers. The patient will sense relaxation. The patient will sense a reduction in pain. At that point in time, once you've completed your oscillations, you can actually add a rotational stretch by moving the bottom of the table so that things are lined up that will help to hold that position. You finish out your treatment, and once the treatment is completed, you re-examine that patient, and again, 9 times out of 10, you're going to find less muscle tone. The tenderness and tension in the supraspinous ligament will be reduced. The alignment will be regained, and you have effectively treated a specific joint restriction without irritating an adjacent herniated disc, or if people are very worried about thrust techniques, this is a very gentle technique. A small clinician can treat a huge patient without putting themselves at risk. Just a wonderful technique. Almost every patient with back pain will have at least one of these conditions, and what an easy way to treat somebody, what a safe way to treat somebody. The key points we covered in module number 3 are, number 1, this is a great technique for specific joint dysfunction that can be used adjacent to herniated discs, for patients that don't want to be manipulated, for patients who are huge, where the clinician is small. This technique is so versatile and can be used in so many different ways. Such an important technique. The second element is that specific diagnosis is essential. There are many different ways to diagnose a positional fault, or whatever term you choose to use for these specific joint problems. It really doesn't matter what technique you use. It's a technique that you must be comfortable with. The third key point is that the type of motion you provide, whether it's a PA, posterior anterior oscillation, or if you use a transverse oscillation through the spinous processes, or using your pisiforms, using a crosshand technique, it doesn't matter as long as you have identified the specific segment, the specific joint that's involved, and that you apply that motion. You can use a stretching motion, or you can use an oscillatory motion. I find that the oscillatory motion is more effective, or even a stretch, moving the table and blocking a spinous process and using the table to stretch while this person is distracted. There are many different ways you can do this. Experiment, find which works best for you. I like the posterior anterior oscillations. They tend to work best for me. But again, try this. It's very effective. You will not believe it until you try it. In module number 4, we're going to demonstrate how to treat restricted movement patterns. We've examined TIM. We examined side bending, we examined rotation, we examined extension, and we examined flexion, and we determined that TIM was restricted in left rotation and right side bending. These movements were not only restricted, but they were uncomfortable. Once you've identified a patient that has restricted movement patterns, the 3D ActivTrac can address these issues very, very easily and very, very comfortably. What we've done here is we've chosen the supine position because we do not need specific stabilization, and in this case TIM seems to be more comfortable in the supine position. The supine position is great for people that have large abdomens or females with large breasts. Many times these patients will choose to have the supine traction treatment. We've placed the lumbar harness 1 inch over the top of the iliac crest, snugged up the belts. We've overlapped the thoracic harness about 1 inch over the lumbar harness. We've snugged up the belts. We've come down to the lumbar end of the table, and we've taken out the slack, taken out all the slack. Right now there's no slack in these belts. We've preloaded them. There's actually a slight traction force, and there's no extra slack up in the thoracic harness. We have TIM in the most comfortable position possible. We have the supine position. We have a little extra support under the neck. We have a bolster under the knees just to relax the back a little bit. What we'll do next now is to program in the protocols. We're going to choose lumbar. We're going to choose intermittent this time. We're going to choose a ramp up time and a ramp down time of 30 seconds. Tim is not in acute pain. We're going to choose a hold time of 1 minute and a rest time of 15 seconds. We're going to maintain 25% force at rest. We're going to choose a treatment time of 15 minutes and a force starting at 40